We certainly appreciate, everybody coming to discuss and listen about a topic that is very much on the minds of people across the country. I know it's certainly of concern in my neighborhood, and I'm sure in, other districts across the state, which is the presence of Ebola, which is certainly a very serious disease. And should it ever come to the state of Illinois, are we doing all the things that we can to be prepared? And in this case, more than possibly any other kind of disease, what Ben Franklin said, hundreds of years ago, an ounce of prevention is worth a pound of cure, is probably very, very true. That the steps that we need to take as public officials and leaders now to prepare should a case ever present itself in this state is going to pay huge dividends in keeping the people of Illinois safe and being sure that if a case ever does occur in the state of Illinois, we will respond to it professionally, calmly, that we will do it in a way that follows medical guidelines and is respectful not only of the needs of the patient, but of the surrounding community as well. And I think it's really worth pointing out here and taking a minute to give some thanks to, I've been briefed on this on a regular basis by, hospitals, by clinics, by the Department of Public Health and emergency managers. And across the state of Illinois, there are hundreds of nurses, doctors, first responders, emergency managers who have volunteered that should a case of this disease ever present itself in Illinois, they are ready and willing to go in and provide the care that is necessary. And I think that's really a testament to the healthcare profession, to our first responders, to our healthcare professionals in Illinois, that people are not waiting to be assigned. They're volunteering. They're saying this is the right thing to do. It's the right thing for our communities and our families, and certainly for anyone who ever might be become a victim of this disease in our state. Just want to make clear, I'm sure that the Commissioner of Health and for the city and the Director of Health will bring this up also, but just it bears saying that there have been no cases of Ebola yet in Illinois. But we have seen in other states where cases have presented themselves on U.S. soil. We know that O'Hare Airport is one of 5 airports in the country where there is enhanced screening for passengers, where people who may have been through a country where Ebola is more prevalent may come. And we know that hospitals, FQHCs, emergency managers, health departments, fire departments, first responders across the state have been regularly drilling and preparing on how to respond so that no one is caught unawares. I think it's also very important to know that we've been paying very close attention to what's happened in other states. We've seen some glitches and some concerns arise in other states around the country when there's been a suspected case or a confirmed case. And here in Illinois, we've been working very carefully and methodically through all of our networks and systems to learn from what happened in other states and be sure that, if we ever have to confront that situation here, we've thought it through and we've prepared for it. The Illinois Department of Public Health is one of a small handful of state laboratories now which is certified to test for the Ebola virus. So when cases might present themselves here, we don't have to send our samples off to another lab in another state somewhere. They can go right to our Department of Public Health and we'll get very rapid and quick results. So that's a very good piece of news for the people of Illinois. And it just bears saying that while we talk a lot about Ebola, and I'll probably steal some of these doctors' thunder here, but this is my speech for today. There's another disease. This is a season for another disease which is far more transmissible than Ebola. We know that Ebola is very hard to catch, but it's flu season, ladies and gentlemen, and we know that hundreds of people are going to be hospitalized, absolutely for sure, this season with flu-related illnesses, and there's going to be some flu-related deaths. So this can be easily prevented. So by simply going and getting a flu shot. So let's have a show of hands. Everyone who has had their flu shot or is intending to get one soon. You can tell that we are a room full of health professionals because I think every hand went up. And this is the most important thing we can do right now for public health, is to be sure that we're being sure that we're preventing the things that we know are going to confront us. So with that, I don't know if Leader Belloc for the Republicans would like to offer any comments.
Thank you very much, Mr. Chairman, and I want to thank Chairman Harris for calling the meeting to begin with, because I think it's better for all of us to get together to be proactive rather than reactive on this important issue. So I want to thank all of you for taking the time to come out today. We have an excellent public health department in Illinois, and I know we have a lot of really good local health departments, but I think we can all share from the information that we have. And again, as Representative Harris said, I want to thank all the healthcare providers, especially those that are volunteering or are intending on volunteering. And I think it's great to be here today, because usually what happens is we have hearings after we have something happen, and then we all talk about what we're going to do about it. So in this case, I think it's a good idea to bring everybody together, and we'll have a full discussion, because people are frightened by it, and the more prepared we are, the better off we are. So thank you, and thank you to all the healthcare providers. I know we've learned a lot from what's happened in other states, but you never know ever what's going to happen until it happens in your own backyard. Thank you.
Representative Fernandez, would you care? Okay. So let me just read the witness list so folks will know who's testifying today. We have Dr. Bashara Shukair, the Commissioner of the Chicago Department of Public Health, Dr. Lamar Hasbrook, the Director of the Illinois Department of Public Health, Dr. Kennethan Kennard, Village of Skokie, Dr. Sandra Martel from the Winnebago County Health Department, George Datella, DuPage County Health Department, Julie Morita, Chicago Department of Public Health, Laura Schneider, Lake County Health Department and Community Health Center, Tom Hughes, Lake County Health Department and Community Health Center, Tony Beltran, Lake County Department of Public Health, and Director Jonathan Munkin of the Illinois Emergency Management Agency. So we're going to do this in a series of panels, so that and if the folks who are here from the Hospital Association, AJ Wilhelmi, and his crew would also fill in witness slips, we'd appreciate that. So we're going to start with Director Hasbrook, Commissioner Shukair, and Director Munkin of the Illinois Emergency Management Agency. So if you could come up, and I don't know who's going to start. Director Hasbrook, identify yourself for the record.
Good morning. Mr. Chairman, Leader Belloc, and members of the committee, good morning. I'm Dr. Lamar Hasbrook. I'm the Director of the Illinois Department of Public Health. And as such, represent the health department that is kind of the point agency for the state. Sure. Better? Okay. And as such, I represent an agency. I am the point person for the agency that's really responsible for addressing our readiness across the state. I also chair the statewide Ebola Advisory Task Force, co-chair that with the Deputy Governor, Crystal Thomas. We've been working very diligently with my colleagues here to the right, Dr. Shukair and Morita, as well as sister agencies represented here by Director Munkin and many, many others that are represented on the task force. And we've enjoyed that collaboration, and I think that's moved us much further along in terms of our need to educate, to mobilize, and to prepare the public health and the healthcare systems to respond to the threat of Ebola. We have, as you know, you've attended some of the press conferences that we've had. We have done everything from distribute and make sure it's been received on the other end guidance. We've stood up a hotline, a statewide hotline, and I'll tell you a little bit about the census because that volume has gone way down from over 200 to less than a handful of calls now. So perhaps that's a marker of the community concern at this point. Protocols, task force, lab testing, as you mentioned, national calls on a regular basis, and efforts to coordinate, and we do this in an ongoing way. Just to reemphasize the bottom line first, there are no cases here in the state of Illinois. We have tested only one case that after some medical management We wanted to make sure we could rule that person out. We actually did that. The CDC guidance has varied or softened just a little bit. Now that any test that we do as a state laboratory that's negative is going to be a final. We don't have to wait and send it and confirm as a negative test. That gives us additional speed in terms of ruling out the diagnosis of Ebola viral disease. Currently, there are 12 persons that are meeting the some risk or the low risk criteria across the state that are residing here right now as we speak, that are requiring some active home monitoring. And that means that they're in touch with their local health department, they're checking their symptoms and their temperature twice a day, and they're reporting that, and there can be some personal visits as needed regarding that. So we do have 12 folks in the state that are being essentially monitored. We have an effort to look at the readiness for the state. We have launched a readiness assessment survey. It was to all of the hospitals, local health departments, first responders, long-term care facilities, community health centers, and others. We had over 1,400 respondents. We asked them specific questions looking at their readiness. Have they received the information, checklist, protocol, guidelines, and things like that? Have they received the training that they needed, both the hands-on and the didactic training? Have they received, do they have the personal protective equipment on site, or can they access that personal protective equipment? And then lastly, do they feel like they're ready to screen, number one, ready to clinically manage, number two, and what is their overall readiness as assessed by them? So here's the good news. What we know is that the hospitals are the most ready of all of these players regarding these sectors, followed by local health departments. We also know that pretty much everyone is getting the information and the guidance they need. That's about a 70 to 80% response rate saying, yes, we have all the information we need, we have the protocols, we have the checklists, we got that. Starts to fall off a little bit in terms of training, especially hands-on training, that is putting on the personal protective equipment, taking it off, those things are hands-on. Starts to fall off a little bit, so that's a gap we're going to have to continue to address. Personal protective equipment, there are some remaining needs out there, especially if you're not a hospital that's really been identified to really be caring for patients of concern. There are some gaps in terms of the need for personal protective equipment and have access to that personal protective equipment on hand and have access to it. Most entities feel better with screening a patient versus actually managing a patient. So that learning curve has to go up as well. And then overall readiness is somewhere around the 40 to 50% range, with, again, hospitals being more ready, feeling more ready, given their role in the response versus local health departments and first responders, and et cetera. And I'll have some of my colleagues speak a little bit more about that. In closing, I just want to say that the state is continuing its ongoing work. Again, working across a number of partners to continue to talk through the plan and forecast ways to address some of these gaps, these systems needs that have been identified through the readiness survey. We have targeted technical assistance through CDC training that we're going to continue to work on. We've identified some needs going forward, and we may need some resources going down the line from the state standpoint to really help us staff a clinical consultation team. We understand we can't get around to all the hospitals and give them the intense training that they need, but the idea is to set up a clinical consultation team or two that they can call us when somebody presents to their doorstep and they want some help in walking through the clinical management and the ruling out of that client. So we're going to need some more staff to do that. The hotline costs money, so that's about $1,000 a day to run that hotline. The census has gone from over 200 to less than about 4 or 5 calls a day, so we can consider disbanding that. But again, I think that's a good thing to have. We have had a lot of up to 700 calls so far since that's been launched. We have some IT needs in terms of being able to track the clients. I mentioned we have 12 right now. We need to track their 21-day windows going forward. We may need additional staff to assist local health departments in contact tracing. That is, if we have a positive patient, then we need to trace all those contacts, and so we'll need some help with that. Personal protective equipment, as well as doing some additional training. So those are kind of some of our wish lists as we project forward in terms of helping the state to be ready. Thank you.
So thank you, Doctor. And we'll have everyone testify. But as I've said to you and to the other folks, who've been here, we are an appropriations committee, and should you identify major gaps in resources, we hope you'll be letting us know so that we can work to be sure that, at all levels, we as a state are providing the resources, be they financial or human or educational, that we need to, meet these demands and, close these gaps. So thank you for, keeping us informed with regular calls and updates. And the next witness will be Director Munkin of the Illinois Emergency Management Agency.
Thank you, Mr. Chairman, and good morning, everyone, and distinguished members of the committee for the opportunity to discuss the preparations of IEMA with regard to the Ebola virus outbreak and its potential impacts on our state. Thus far, our agency is really focused on contingency planning, training, logistics, and communication between local emergency management, health officials, and the first responder community statewide. Our contingency planning consists of options for scalability up to large-scale operations or response if positive cases are identified in order to ensure a timely, effective, and coordinated response among state and local agencies as we would for any natural or man-made hazard as we do on a regular basis. Training efforts right now are really focused on vetting and disseminating standards for individual training for first responders on topics like donning and doffing of personal protective equipment to make sure that that's being conducted properly, as that's one of the primary areas of concern for folks that are providing treatment in those circumstances. And then making sure that we have planning requirements for implementing a community quarantine if it's necessary, recognizing that that does include all aspects of public safety to actually perform. And then the development of executive and unit level training such as tabletop exercises or test scenarios and the corresponding actions, roles, and responsibilities of the participants in those exercises. Our logistical efforts are really focused on the establishment of a strategic reserve of personal protective equipment or PPE to ensure that no healthcare workers would be at risk of exposure during treatment of a potential positive case due to a lack of available PPE. So to this end, we did an analysis utilizing the planning factors provided by Dallas after their treatment of their patient that resulted in up to 50 sets per patient per day in order to make sure that they had enough PPE for all of their healthcare workers. So what we did is we utilized that, extrapolated it for a 21-day period, even though in most cases that's probably in excess of the amount of time that a positive patient would be in the hospital. But we wanted to make sure that we had up to 21 days worth of coverage at 50 sets per patient per day, and that resulted in what we call a mission-ready package of PPE that we can push to a hospital facility if they do receive a positive case and they do run into issues with running out of adequate PPE. We currently have enough supplies collectively between the state and some of our mutual aid organizations in the state to provide 2 of those mission-ready packages. Keep in mind that's over 5,000 sets of PPE, so it's a lot. But we do have 2 of those packages that are ready to go if and when they're needed, and we intend to procure enough supplies to give us a total of 5 of those, which would give us enough to treat 4 patients at the hospitals that have already been identified as centers of excellence, and then an additional 1 in reserve. So a very, very important thing to recognize is that PPE is, and that we have available, is not intended to really provide day-to-day supplement of what hospitals are utilizing for PPE. It's solely for the purpose of making sure that under no circumstances will they actually run out of PPE if they do in fact have a positive case located at the hospital. So as far as request procedures, we've coordinated with the Department of Public Health. They will be the agency that people can request those push packages from to make sure that they can go through the process of certifying the need, identifying what the circumstances are, and then providing us with instruction to provide it. We can use the Strategic National Stockpile framework that's already in place in terms of storage, delivery, transportation, and all of those things. So we already have a system in place to be able to do that. And it's important to recognize that we're not, this is not designed for any purpose of circumventing the standard procedures that hospitals and healthcare workers go through in order to procure and get additional PPE. Right now, that stockpile will only be deployed at the request of IDPH, and then only when local supplies have been exceeded to make sure that we have that backstop. We're also in the process of procuring those additional supplies, as I mentioned, right now at a total cost of about $180,000 to $200,000 to have that on hand, and we're currently leveraging some grant funds to accomplish that. We're also coordinating with some of the mutual aid organizations in the state, like MABUS, the Mutual Aid Box Alarm System, which is the fire services mutual aid in the state, and they're the ones that are the controllers of the 42 level A hazmat teams, hazardous material teams in the state. We're coordinating those purchases with them as well to make sure that they have some more local resources that can be made available if and when they're needed. and then make sure that county and municipal public safety personnel can have access to that. Communication right now is accomplished through electronic distribution of updates. We are having weekly meetings at the State Incident Response Center in Springfield with the liaisons of all the state agencies and mutual aid organizations that have a stake in this process, just to give them updated information and any changes that are happening to make sure that they're maintaining the most current information available. And as always, we stand ready should we be needed in any operational capacity, if we need to be stood up. And that constant communication between us and the Department of Public Health has proved very effective and valuable to make sure that we're ready for any eventuality. So with that, I'm happy to take your questions.
Okay, well, let's have Dr. Shakir make his presentation, and then we'll go to questions if that's all right.
Thank you. Good morning, Mr. Chairman. Good morning, members of the committee. With me today is Dr. Julie Morita, who's the Chief Medical Officer at the Health Department in Chicago, and she is the incident commander for our Ebola response. In the quick overview, we're going to be talking specifically about what we've done in Chicago when it comes to preparing and responding to potential cases of Ebola. I do want to start by pointing out that really the only three countries where the outbreak is still happening in Africa are Guinea, Sierra Leone, and Liberia. And it's really important to know that these are the only three countries where the outbreak is not controlled. And until we control the outbreak in these three countries, we're going to continue to be at risk in the United States. I know that we focus a lot of our efforts on Chicago and Illinois and the United States, but really the most important thing in that effort is controlling the outbreak in those three countries. This is the largest outbreak on records. We continue to see new cases. We continue to see deaths in these three countries. The good news in Nigeria, the outbreak has been controlled. We're not going to go through a lot of these slides. This is very common right now, what the early symptoms are for Ebola, the incubation period for Ebola. I think we're all very comfortable with those, and we know those. Fever and fatigue has been the most common symptoms that we're seeing in this current outbreak. And I think it's really important to know that we do not get Ebola unless there is direct contact with body fluids, with objects contaminated with the virus, and with infected animals. And it's really important to know that that's the only way you can get Ebola. Just a brief overview of what has happened in Dallas. On September 20th, Thomas Eric Duncan arrived in Dallas from Liberia. He went on September 25th to Texas Health Presbyterian. He was sent home. He came back on September 28th, and he was placed in isolation and tested positive for Ebola. On October 12th, the first nurse who treated Duncan tested positive for Ebola, and another nurse on October 15th tested positive. Both of these nurses now are clear of the disease and have been sent home. Also in New York City on October 17th, Dr. Craig Spencer returned home to New York after providing humanitarian care in Guinea. He started developing symptoms on the morning of October 23rd, and he tested positive for Ebola virus that same day. And then many of us remember the state of New York and state of New Jersey implemented mandatory quarantines order that caused some concerns amongst the public health community that we continue to track. Here in Chicago, our planning started over 3 months ago when we've started holding regular briefings with Chicago Hospital. We provided a lot of assistance to healthcare providers. We've developed fact sheets to residents. We've developed guidance to our first responders in the city. And we've worked with the CFD, with the Chicago Fire Department, to modify their 911 scripts to include travel history questions and others. This is really the four key areas that we focused our Chicago planning around Ebola. We focused a lot of efforts on the screening that's happening at O'Hare and traveler monitoring protocol, and Dr. Morita will be covering those. We spent a lot of time with our healthcare system preparedness, and whether through developing the Ebola resource network for hospitals, but also working with all area hospitals. We spent a lot of time on, and we continue to spend time on community preparedness around public messaging, community engagement, and we do a lot of intergovernment collaboration, whether it's within city government or with our partners at the state, and we continue to work very closely with the CDC. And over the next few minutes, Dr. Morita will go into more specifics as to some of those efforts along these 4 different areas.
Good morning. Thank you for this opportunity. What I wanted to do first was to provide a little more detail about what's happening at O'Hare Airport. I think there's a lot of questions. There's a lot of questions regarding what's happening at O'Hare Airport. Before travelers actually arrive in the United States and before they actually leave Guinea, Liberia, or Sierra Leone, all travelers are screened before they exit. So they have their temperature taken, they're asked a series of questions regarding exposures they may have had to sick individuals, and they're also asked questions about symptoms that they may have experienced. If anybody says yes to any of those questions or has a fever, they are not allowed to travel. As of the middle of October, we had heard reports that there were about 36,000 people that were screened, and of those, 77 were actually unable to travel, but none of those people actually had Ebola. Most of them had malaria. What was established here in the middle of October is entry screening. So at JFK, Dulles, Newark, Atlanta, and at Chicago O'Hare, we have had established a screening system for all people arriving from these 3 countries. Customs and Border Protection staff, as well as CDC staff, evaluate these travelers. They take their temperature, they ask them a series of questions regarding symptoms and also possible exposures. If they answer yes to any symptoms or they have evidence of being ill, those people are evaluated. If they have report any exposures, then they are referred on for other further evaluation. The risk determination is made based on the individual's reports of possible exposures. So someone is considered at high risk for having had a high risk exposure if they had direct contact with infected body fluids, so blood, vomit, or diarrhea, and if they had contact with those things on their mucous membranes, some of their mouth or in their eye or in their nose. People that are considered at some risk of Ebola exposure were people who had close contact with a person showing symptoms of Ebola in a household or in a healthcare facility or in the community. And those who are considered to have low or not zero risk have been in the country with widespread disease but don't report having any known contact with someone who is ill. So as soon as someone arrives in the United States in any of those 5 ports of entry, they're given this kind of a classification. What happens is the groups, after being classified as either high, some, or low, or no, or not zero risk, they're also evaluated to see if they have symptoms. So travelers who are symptoms are sent on for evaluation in a hospital in Chicago. Travelers who are asymptomatic do not necessarily require health care, but are classified, and then they're monitoring. How we handle them when they're in the United States is affected by which category they fall in. So their disposition might include quarantine of those who had high risk exposures. If they have some risk exposures, those people would not be allowed to travel by public or commercial conveyance. And then if there's low risk of exposure, then they're allowed to go about their usual business, but they must comply with daily monitoring, twice-a-day monitoring. So I'm going to get into a little more detail about the monitoring. So what we're doing is everyone who arrives from any one of these 3 countries requires daily monitoring. And that means if you're asymptomatic with low risk exposure, that's the least amount of monitoring that we have to do. And those individuals are allowed to report to us on a twice-a-day basis their temperature and if they have any other symptoms. And we can do that by phone, by text, by email. That kind of communication is allowed because they're considered to have low-risk exposures. Those that are asymptomatic with some risk of exposures are not necessarily allowed to travel by commercial conveyance or airplane, long-distance train or bus, and we're not allowing them to travel by Chicago CTA, so mass transit's not allowed as well. And they also have the twice-a-day monitoring. Thus far, since the monitoring has been established, Dr. Hasbrook mentioned that there's been a total of 11 people being monitored here in the state of Illinois. Chicago has ranged between 3 to 5 individuals that we're monitoring on a regular basis. And they've all been within this low risk of exposure or some risk of exposure, nothing higher than that. The highest risk group of people are actually those have to be home quarantined, so they're not allowed to leave their homes other than for taking a jog, maybe raking their leaves, as long as they're not in close contact with anybody. But these are people who had blood splashes in their mouth or in their eyes or in their nose, so they're considered at higher risk for getting disease. They're also not allowed to travel by commercial conveyance or CTA. So for symptomatic travelers, a lot of what we've done over the past few months has really been focused on making sure that we're able to care for someone who comes in who is diagnosed with Ebola. What we saw play out in Dallas and we're seeing now in New York City is it's really important to have an established healthcare facility that has appropriate systems in place. And in anticipation of that, CDPH has been meeting on a regular basis with all the hospitals in the city of Chicago. And what we did is we were able to narrow it down to a group of hospitals that we felt had greater capacity. And the criteria that we used for this greater capacity was that hospitals had to have specialty care expertise. So they had to have infectious disease experts. They had to have intensive care expertise. They had to have kidney or renal dialysis expertise as well. They also had to have the resources to support the usual care of patients on top of an Ebola patient. What we know from what happened in Texas, what's happening in New York, is that hospitals that care for a patient with Ebola require many, many staff just to focus on that individual patient. And if a hospital doesn't have the resources to support that and their usual source of care, they're not going to be able to function appropriately. And so we had to seek institutions that had that capacity. In addition, we looked for enhanced laboratory capacity and systems, advanced infection control systems, understanding of the waste management systems involved, and also a willingness to care for Ebola patients. What we've witnessed in the hospitals that have cared for Ebola patients in the United States is that these hospitals have suffered as a result of it. Some patients that do not have Ebola will not go to them for usual care. And so these hospitals are taking on a risk by assuming this responsibility. So we wanted to make sure that no one felt coerced to assume this responsibility. So we were able to identify 4 hospitals within the city of Chicago. They include Rush, University of Chicago, Northwestern, and also Lurie Children's Hospital. And that serves as the Ebola resource network within the city of Chicago. Concomitant to our identification of these hospitals, CDC also sent a team to help assess their level of readiness. So during the week of October 19th, they were here to observe the PPE that was being used, the training that was being done, the facilities and the plant layout within the facilities themselves to make sure they really truly were prepared. In addition to having appropriate healthcare facilities to care for these patients, we also recognize that it's really important for places that are referring patients to the hospital to have criteria so they know who they should be referring to these hospitals. What we were concerned, and the hospitals themselves were concerned about, was that the hospitals, by assuming this role as an Ebola care network, they might have to be responsible for caring for or screening all patients who think they might have Ebola. So somebody who was in South Africa or in Kenya who came from those countries and said they had a fever, they didn't want to necessarily evaluate those patients because they'd be overwhelmed with those folks and not be able to focus on a true Ebola patient. So we established some clear criteria. And this slide really summarizes the criteria that need to be done. So from O'Hare, if a person arrives from any of those 3 countries, has symptoms consistent with Ebola, the CDC physician is actually evaluating them, and then it would be appropriate to refer to the network hospitals. From our community hospitals, what the network hospitals ask is that an ID physician be involved with before a referral occurs. What we have experienced is calls from hospitals saying, I have someone from Kenya who's vomiting. And that's not really considered to be a high-risk person for Ebola because there's no active disease going on in Kenya. And so I think we have to be able to tease those low-risk situations out so our hospitals do not get overwhelmed. By having an ID physician evaluate them, we are able to do that. From our clinics in the city, what we've done is we disseminated broadly guidance for them to use as criteria for identifying who might be high risk. And we've asked that if they have concerns about someone having Ebola, that they call the CDPH hotline. So Dr. Hasbrook made reference to wanting to have a clinical hotline available so doctors can call throughout the state to get guidance on whether or not this is really something to be concerned about or not. And we at CDPH are kind of serving in that capacity locally, so we've asked all health centers to give us a call if there's any concern about an Ebola patient, and we can help them walk through the process of deciding whether or not these people are truly at high risk or not. Is it appropriate to send to a resource hospital or not? But I'll tell you, there's only a handful of us physicians that are actually able to take these calls, and so it'd be nice to have additional support throughout the state. The last area where we feel like patients might arrive is from the community. We would expect that there might be a phone call that comes in that says, somebody says, I was in one of these 3 countries, I have a fever, I need to be taken to a hospital. And so we've trained the paramedics and we've given them guidance and protocols to follow so they also know to ask, is it these 3 countries? Is it these symptoms that you have? And if that is the case, then they are allowed to go to an Ebola Resource Network hospital. So we're trying to establish systems so we're using appropriately the limited resources that we have. Okay, so these are just, again, the summary of the hospital and clinic recommendations that we made to them so they knew who to refer and who was appropriate. We're also working with fire department, the CFD and private ambulance companies to make sure that they have the appropriate PPE that they need so that they don't actually get infected if they're transporting a high-risk patient. I think what we have, fortunately, because we had established this network of 2 weeks or 1 week after identifying the network as a whole, we actually had an opportunity to test this. And so we had 2 people arrive at O'Hare on the same day from those 3 countries who had symptoms and had to be transported to 2 of the 3 network hospitals, 2 of the 4 network hospitals to receive care. And so it really allowed us to test the systems that they have in place, also our systems for transport and ongoing support for individuals who are here in the city of Chicago as a result of their family members being hospitalized for evaluation. So I won't go over the details. I think you have handouts so you can read the details later. In addition to our work with healthcare facilities, we've done some community healthcare, a lot of outreach effort to other healthcare facilities, hospitals, federally qualified health centers, private clinicians. We're going canvassing door to door to make sure that all clinicians have copies of our guidance. We've done public outreach within the community to allay concerns and provide support. So we've done work with our West African community as well as the general public and also elected officials. I think what we wanted to really communicate to you all is several things. I think the realities of Ebola is that it's hard to transmit. There's no cases in Chicago right now. However, as long as there is active disease in West Africa, we will be at risk for having introduction of disease here in Chicago and the rest of the United States, and that we cannot let our guard down. Though the media may not be as interested in the topic or the community may not be as concerned, we still have to have high levels of preparedness so that we don't have problems that can be experienced with a lack of preparedness. In addition to that, I think there's a really important role of us working together as we prepare, because I think there's been cross-collaboration between our agencies and other agencies beyond, but it needs to go on as an ongoing basis. And then lastly, what I'd like to say is that I know that the Northern Illinois Public Health Consortium will be presenting their statement later today, and I think what CDPH has done really is an example. We've had a fortunate opportunity to share with you great detail about what it is that we are doing, but what we are saying and describing here is really consistent with the Northern Illinois Public Health Consortium will be describing in terms of the needs of local public health as a whole. So thank you for this opportunity.
Thank you, doctors and director. So, I just had a couple questions. So, if let's take the example, if somebody were to present at a hospital or a clinic or a local doctor's office that was not one of the resource network hospitals, then what would be the protocol if that was a suspicious case, and how would that person get transported to an appropriate place for care?
What we've done is distribute guides. CDC, we distributed some guidance, and then CDC followed shortly afterwards with some outpatient clinical guidance. And the guidance itself really informs and helps healthcare facilities to know what questions to ask. So they should ask, number one, have they been in those 3 countries in the past 21 days, and what symptoms do they have? And then if they have, say, yes, they have been in those 3 countries in the past 21 days, and they have symptoms that are consistent with Ebola, we ask them to put them immediately into a private room where they won't be interacting with other folks. And then we also ask them to limit the number of people that are interacting with them while they're in the clinic facility itself. And we ask them to reach out to us at CDPH to help them walk through what the next steps would be. And the next steps would be, if it really turns out this person has been in those 3 countries and does have symptoms that are consistent with Ebola, we would help to arrange transport of that individual from that clinic to a network hospital. But it can also be in an emergency room that is a non-network hospital. We can arrange for that kind of transport by a private ambulance company. So we've been working closely with IDPH and on establishing and understanding the licensure related to ambulance companies, private ambulance companies, so they're able to transport these patients, and they know what to do and what the standard is, best practices to transport them safely. And then we would communicate to the Ebola Resource Network Hospital that one of these patients is arriving, so they would be prepared and get the patient taken to the appropriate place, and their staff is well prepared and appropriately protected.
So I know early on, just anecdotally talking to some emergency department directors, that they saw, I think the term is, a lot of worried well. A lot of people are like, oh my goodness, I have fever and flu, or I vomited, or whatever. Have we seen a decrease in people presenting with concerns, or is that still an issue?
My sense is that we continue to get a slow, steady stream of people that come into an emergency room for evaluation. Just last week, we had at least 3 situations where someone came from a country outside of those 3 countries complaining of symptoms, and we got calls from the emergency department. But we were able to say, these are not high-risk individuals. You can do some other testing, evaluate them, and rule out Ebola and rule in something like malaria. So it turns out one person was pregnant, and that's why she vomited. The other person had malaria, and that's why they had a fever. And so though there are not as many as there were earlier, we still have a continued persistent demand.
And
So-
I would add to that, Chairman, that we're trying to get hospitals, every clinic that deals with patients to think Ebola, but not overthink it. So really start with that first screening question to make sure there's any exposure whatsoever, and then put your other cap on and start thinking about a regular differential diagnosis that you might entertain otherwise. So think Ebola, but don't overthink it. The other piece is, again, I would point to the hotline in terms of kind of monitoring the public concern, because of those 700 calls or so, probably about 100 of those calls were healthcare workers themselves trying to get additional information. Now we're getting less than 5 calls a day. So that kind of gives you some sense of what the community level of concern and worry might be.
So, getting more into the mechanics of how this would work, I know earlier in some of our discussions when this first started to present in the United States, there was concerns about, the supply chain for PPEs and, just the manufacturers and distributors and suppliers having to ramp up because all of a sudden, everyone in the United States wanted them. Are you seeing an easing of, I don't know if this is a question for Dr. Hasbrook or Director Monken, are, the manufacturers, ramping up their supplies of these?
Yeah, we've seen some varied timelines from some of the companies that we have contracts with to resupply on PPE. The better case scenarios for some of them is delivery early January. The bad case scenario or worst case scenario is delivery in the March timeframe. So there's definitely some significant concern out there about resupply and whether or not we can continue to get it at a pace that we would ultimately need it. But we're working closely with those companies to figure out what we can do, even if it's a matter of getting some partials or trying to balance out what they're doing and what commitments they already have for deliveries, and seeing if we can balance that out as well.
So is that an issue of we need more contracts, or are all the manufacturers and suppliers being overwhelmed or with
I think it's more of the
demand?
latter than it is the former. So I think really what we're seeing is system-wide, there's only a handful of companies nationally that can handle the volume of demand that's currently being requested. And as a result of that, I think that all of those companies are being overtaxed in terms of their standard supply chains for what their expectations were. So we've worked with several different companies just to make sure that we're spreading it out as much as possible and really working with the timeline that's most conducive to what we think our needs will be.
But for the time being, since there are no cases, we're ready to address some should they present themselves.
Yeah, absolutely. So we've really gone through such a deliberate process in the last several years of making sure that we have adequate supplies for hazardous material teams and groups that we use with regularity. I mean, we use hazmat teams for everything from oil spills to assisting state police with taking down meth labs. Those are all things that require hazmat capability. So we do have a great baseline capability statewide to perform hazardous materials handling. And as a result of that, we have some fairly significant amounts or quantities of reserve PPE that we can leverage in this particular circumstance if needs be. So I feel certainly confident in the short term. The only thing that would change that circumstance is if we saw a difference in the presence of cases in the state that would necessitate a significant increase in both the demand and the consumption of PPE.
Good. And just as a housekeeping matter, will the clerk please add Representative Lilly to the roll? And so powers of quarantine, and it sounds like a lot of the if people are on the lower level of exposure and possibility, how do we guarantee that people are abiding by the rules and restrictions that they need to abide by, if they have on the low risk of exposure?
Well, as you know, the powers of quarantine reside with the state, and we delegate that to the locals. And so we're all exactly what Dr. Morita described. We're doing it across the state. Every single local health department are basically doing it across the state. The higher risk, the more we're going to be kind of in their face. We're going to be doing more in-person visits as needed and less remote through emails and text and phone calls. Compliance is a big issue as well. So we really try to come up with something that's common sense, protect the public, but not restrict people so much where they can't rake their leaves or ride their bike and do some things like that. So we're trying to we have flexibility in there where you can kind of use a case-by-case judgment. But basically, it comes down to compliance. If they're complying with their reports, every day and reporting out what they need to and taking those temperatures, and they get a care kit so they can monitor and log everything. They're doing that. Then we have eyes on them, then we're pretty confident. But we can, and we do, in some of the high-risk scenarios, do in-person actually visits.
And we've been doing this for almost a month right now at the health department, and at any one point, we have anywhere from 3 to 5 people under active monitoring, and we've engaged those individuals, we've met with them individually, we've discussed what the plans are. We actually developed agreement forms that they have to sign, that they understand what they're expected to be doing and how the communication is going to be, and we have been engaged regularly in phone calls, but also we have teams of nurses who are doing home visits on these individuals, checking in personally with these individuals, and we haven't had any significant issues with compliance so far. We continue to monitor this very, very closely, though.
Thank you. Other Representative Belloc and then Lily.
Thank you very much, and thank you all for testifying. I wanted to ask, so Dr. Hasbrook, I wanted to see who really is in charge. Is the Illinois Department of Public Health really in charge of the whole thing? Would you take all the numbers back from everything that was going on in the state and different hospitals? Because we have you here today in the city of Chicago, but it could be anywhere in the state. So it seems as though when it all started to happen, there was a lot of discrepancy as to what the CDC guidelines were and how to enforce them. So I guess in our state, I'm wondering if it's our Illinois Department of Public Health who everybody would turn to, or is it local departments of public health?
Well, I would say it's a bit of both. I mean, the buck stops with the Department of Public Health, so I would say yes. But it is a coordinated response, and we delegate a lot of our authority to the local health department because all public health is really local. So here in the city, CDPH is taking a very lead role, and they're working directly with CDC. We're involved in that. Outside of the city, we're looking to identify network hospitals who could provide that referral, who could step up and be a center of excellence for care outside of the city. And so it's really about coordinating and making sure all the guidance is being shared and everybody's on the same sheet of music. But ultimately, the state health department has the powers of quarantine, the powers of isolation. We are, in regular contact with the feds in terms of all the guidance. So we continue to modify the protocols that Dr. Morita described in terms of the different risk categories, in terms of what you need to do with restricting their movements. We also have the ability to make an order for an involuntary quarantine and enforce that with law enforcement. So we have that whole spectrum. Right now, most clients are really being, voluntarily understanding. They're signing these administrative orders. They understand what they need to do, and they want to take care of themselves and protect the community. But we do have that additional force if we need to. So we're really kind of quarterbacking it, but we're all taking a lead. Certainly in the city, the CDPH is taking a big lead role as well.
Okay, but so what you just said was this: the city of Chicago is more going straight to the feds rather than to you. Is that correct?
No, what I'm saying is that because of the relationship that they have with the feds, they can actually go directly to the feds as well for additional training and on site. We're in contact with the feds on a regular basis as well. So we're kind of doing this in coordination.
Okay.
Can I add a little bit? Excuse me.
Pardon me?
If I speak? Part of the reason that CDPH or Chicago works directly with CDC is because a lot of our federal funding comes directly to us. For several of our programs, including Preparedness program, the funding doesn't go to IDPH and then come to us. So we have established systems in place where we receive funding directly from CDC for preparedness, for immunizations, for STI, HIV. As a result, we often work directly with them. So we always reach out to IDPH and say, we're working with CDC on this issue, or we're coordinating this activity. But we have the opportunity to work with them more directly than the other local health departments do.
Well, I'm glad you brought that up because that was going to be my next question as far as funding goes. So if the Illinois Department of Public Health is getting funding from the federal government, or is it just coming out of state funding, all the preparedness? Because it sounds like a lot of administration and then IEMA with the emergency kits and everything.
Well, there's several funding streams. So they get a direct funding stream for preparedness. We get a direct funding stream for preparedness also from the federal government, as does IEMA. And so it's really about harmonizing those funding streams and coordinating and having a blueprint and a plan so we can mobilize, share PPE across different centers, across different counties, et cetera. So we all have direct streams. And so when we put our wish list together, it really is about what the state needs specifically to help assist maybe the city, maybe less so the city, but also health departments outside of the city.
So I think that your comment was good because it seemed to be from just people that are watching all of this on TV and what was happening is that the woman who left wherever it was, Washington, I think, or I can't remember, and went to Maine about the quarantine issue, is that a lot of people were saying, well, who does that enforcement? So you're saying that it's the state that does the enforcement, not the CDC. So we wouldn't have the CDC come in. It would be up to you.
That's correct.
And so going further on that is that if people come into the United States, a lot of people have said to me, well, what if they come, because a lot of those people, when you trace their steps, did not come specifically from those 3 areas in Africa. They went to Europe and then through. There were a couple of people that did that. So when people get off an airplane, are they just scanning anybody that's coming from anywhere, European or Africa, or is it just flights from those 3 countries?
So the people that are screened, what happened is at the federal level, there was a decision to have all people flying out of those countries directly to the United States. Those flights are all channeled through these 5 airports. But you're right, there are some people who will fly to another country and then arrive in the U.S. after
Right,
a
it's
couple
not
weeks.
just specifically those
Right.
3 countries.
No, well, it is those 3 countries that
Have it,
the
but
5 that come
one
into
had
the
gone
5
to
airports.
Germany, I think, and flown from Germany over. I
Right,
just
but
was one.
So the flights originate in, so we don't have any direct flights from those 3 countries to Chicago. What happens is the 3 flights originate from those countries, end up in Brussels, and then they come here.
I see,
And so
okay.
those folks are actually monitored. But in addition to that, the people who may get off and stay in London for a week and then come to the United
Right.
States, the Customs and Border Protection always reviews the passports
Okay.
and
Oh.
identifies people that originated from those 3 countries. And so we're getting some of the travelers that are coming through O'Hare, we're hearing about them, and they may have originated in those 3 countries, but it may have been 6 months ago, but we still hear about them because then they're no longer considered at risk, but we hear about them because Customs and Border Protection is looking at their passports. So we're able to identify them that way.
Oh, that's good. Thank you very much. And just back to Dr. Hesbeck, the hotline, is that being, I think I read somewhere, is that being run through the poison hotline?
It is. The
Okay.
Illinois Poison Center. Yeah, but it's identified specifically as Ebola hotline. So if you were to call the number, they would answer Ebola hotline and have the scripts to walk you through. So there'd be no difference in terms of the consumer thinking they're getting the poison line versus the Ebola line.
Okay. And just back to the quarantine for 1 minute. So if a person shows those, whatever you feel are the, the outward signs, then you would step in and say that this person has to be quarantined for, and that follows the guidelines of the CDC for 21 days. Is that correct?
Essentially, and the CDC's guidelines have been changing a little bit.
I
but
know that seems to be part of the problem.
Yeah. So when I spoke with Dr. Frieden, the CDC director, a couple of weeks ago, it was a day or 2 before they actually released their guidance, and our guidance was already out, had been released that Friday. I spoke to them over the weekend, so it's basically in alignment with what they're doing. What we're doing is essentially what they're doing. In terms of the powers of quarantine, those are essentially. We've had refresher training with all of the local health departments. So we certified 96 local health departments, including the city. So we've had calls with them, webinars to kind of talk them through the forms you need, the difference between isolation, quarantine, voluntary, involuntary, how to enforce it, modify all those forms. And so we've had some refresher courses on that. So what would happen is as they come through the quarantine station and they have a destination somewhere outside of Chicago, then we would enter their information. We could track their information electronically. We'd let the local health department know this person is coming into your jurisdiction, and they would reach out to that person and do the local active monitoring right there. And all that's tracked in an electronic system that we can see.
Great, thank you. I just had one other question because I had somebody call in the other day to ask about the military because they're child was going over as one of those troops, I think, and they said, what happens upon return? And it seemed as though the CDC wasn't quite straight on that either, as far as if they were going to quarantine all of those military people from the U.S. that were over there. Are you familiar with that?
I can tell you that.
That's okay. Oh,
Yeah, I can tell you that from the perspective of what's happening, both with non-Title X, so non-federal military personnel, Guard and reservists that are being
Right.
utilized in some of these capacities, that decision's ultimately made by the Department of Defense. So they're consulting with CDC, but Department of Defense has final say on what they're doing internally with their personnel. So in some cases, you've seen some soldiers that returned back from the impacted area and came back to Italy, and they were quarantined once they returned back to Italy. Vincenza is where they're based out of. But right now, that decision resides within DoD for their own personnel only. They can't affect policy outside of DoD.
Really?
It's just what they're doing internally based on their own assessment of the level of exposure and risk associated with those individuals. And thus far, even though some National Guardsmen from other states and some reservists from other areas of the country have been utilized at this point, no military personnel from the National Guard or reserves have been utilized based out of Illinois.
so they don't have to abide by the CDC guidelines. They could just abide by their own guidelines?
Well, yeah.
I would,
It's a difference between what's required and what's advised is
the
ultimately.
CDC makes recommendations
Right.
for many health-related things, and so like for immunizations in particular, they make recommendations, and DoD often follows them to the letter. And so I believe what will happen, the guidance that came out from CDC is what we've all been using locally and in state health departments. DoD will look at the guidance, and it's really based on risk. Did the person have any exposure to someone with Ebola? Did that person have exposure to blood or body secretions of a person with Ebola? And if they did and they had a high-risk exposure, those people would be likely being quarantined. If they were there building a building and there was no contact with a person who had Ebola, then it's much more likely they're allowed to go about their usual activities. So it really depends on the spectrum of the work that they did in terms of what restrictions they would have placed on them when they return home.
Thank you.
So one other question we talked about, I just sort of forgot to ask this, was in Texas in particular, we saw after the person had gone back to their own private residence and there had been illness, I think we have contracts in place with appropriate contractors if somebody were to get sick in a private area who can go in and do the clean up and appropriately dispose of any household waste and such.
So within the city of Chicago, we have a contract with an organization that will do cleanups for us for hazardous materials. And they have a subcontractor who actually has the ability to deal with crime scene investigations, which is much like dealing with an Ebola patient because it's concerned with bodily fluids. And so that contractor is able to do that, is familiar with CDC guidance and recommendations, and is prepared to do that for us if we need it.
Good. So they're ready and already in the system. Great. Representative Lilly, did you have a question?
Thank you, Mr. Chairman. Real briefly, as you all know, we did deal with legislation that kept our poison center up and alive, and prayerfully, they are holding a part of the team to handle this issue. The calls that are coming in, at what rate are they coming in, and are we creating a calming effect with some of those calls?
Thank you. So initially, when it was launched, we had, I think, in the first day about 80 calls. The next day, it peaked out at about 225 calls. Since then, the second week, it was in the 30s. Now we're getting about, I think our last count, 5 calls, 2 calls per day. So the census is really, really going down. We've also kind of categorized them by type of caller. Healthcare workers, of the nearly 700 calls, we've had about 80 healthcare workers calling. Now we're just getting general population. So I think that if that's a signal of the community's concern and fear, I think those are dampening quite a bit.
Great. The hotline, the Ebola hotline, is that a public number, or is that just a number that health providers know about?
It's public. It's a 1-800 number, but it's public. And so we have general public calling as well as health workers. Anyone can call that hotline.
That's a different number from the poison hotline, or is it just a connection?
It's a connection, but the person on the other end says Ebola hotline. So it's designated. So
be like the Home
Yeah.
Shopping Network and say, what number should people call?
you want the, oh, okay.
Yeah.
All right. So it's oof, boy. I'll have to give that to you. I don't have it offhand.
And then the last question I have, as elected officials, what should we be doing and what our role could be in this process?
Okay, sorry, let me give you that number. 1-800, oh, sorry, 1-800-889-3931. 1-800-889-3931, correct? I thought you were looking it up. Okay, I think that's it. I'm pretty sure. I'm sorry, what was your follow-up?
Yes, I'm sorry. As elected officials, what should our role be and what exactly should we be doing in this process to assist?
Well, from my opinion, I would say that initially you need to become aware and educated at the journal level, which is what this hearing is doing, so that you can allay the fears of your constituents. You can have the resources at the ready, like the hotline and other things. So I think that's important. I think in addition, be standing poised to help us with additional resources that we might need to get those clinical consultation teams up and running, to continue to support the hotline, to continue to address some of the gaps and some of the needs that we identified in the readiness survey, such as personal protective equipment, training needs, and the like.
I would definitely highlight as well, the most important part is the communication piece of things, making sure that holistically through the healthcare network and then the first responder network, that any conversations that can be facilitated, recognizing that in a reverse sort of way, Chicago is one of the easier places to deal with solely because they have a Department of Public Health, one police department, and one fire department. And that's one of the challenges associated statewide is we have over 1,100 fire departments and over 1,000 police departments statewide to go along with the 96 health departments. So anytime that crosstalk can be facilitated, I'd strongly encourage you to do so.
Thank you, Mr. Chairman.
Your
Thank you.
Representative Hernandez.
Thank you, Mr. Chairman. And I just want to thank you very much for your quick planning and preparing for just in case, if we have an outbreak. Just going back a little bit, and I think Representative Belloc kind of hit on some of the points that I wanted to ask, but I just want to detail it a little bit more. You spoke that there's currently 3 countries that are still viewed as having the outbreak. One that has been contained, and that's Nigeria. So overall, how many countries, though, have had the outbreak? Is it just the 4? And to follow that, what is containment? What do you mean by containment? How does that get across to that it's safe? How would the public know that, okay, those who are traveling and coming from Nigeria, it is a country that's so what does that mean?
What does that mean? Sure. So in Africa, there were 5 countries that had Ebola cases, and Nigeria. So it's the 3 countries that we've been talking about. The Nigeria and Senegal also had some cases as well. But Nigeria and Senegal were able to stop the transmission of disease, so they have no longer had new cases develop. And the reason they've been called they can say that there's no widespread transmission is because 2 incubation periods. So one incubation period is 21 days. They allow, after 2 incubation periods had passed and there was no new case that was identified, those countries were considered free of widespread transmission. And so that's the definition that we would use. Now, the United States has been defined as a country that has experienced Ebola because we have had the 2 cases that occurred or were diagnosed here in the United States, but there has not been widespread transmission. We've had a couple nurses who got sick after the first case was identified, but none at this point from the second case that was identified. So we've had cases, we do not have widespread transmission at this point.
Okay, and in terms of the screening, so are individuals screened before they leave the countries that are in a state of outbreak state? They're screened before they leave the country, or they're screened at the point, so you say there's no direct flights from these countries to the United States. So where is the screening take place? Is it screened before they leave and then screened at the next point of travel?
So the screening that is occurring is in Guinea, in Liberia, and also in Sierra Leone. Before an individual gets on a plane to leave the country, they are screened. those individuals may have layover flights in other countries, and I don't know if there's actually screening going on there, so there may not be. But then, and then when they arrive here in the United States in any of those 5 airports, they are screened as well when they arrive here. So there's 2 levels of screening that occur: one before they leave one of the 3 affected countries, and then one when they arrive in the United States.
Okay. And then one more question I had, and I can't seem to find it. How many contained? So we also talked about, so CDC is setting the guidelines, but, and we're aligning with those guidelines as a state. But does that mean we also, we align, but basically could individualize our own guidelines, just as long as it's at some respect aligning with the CDC? Would that be correct? So we can go a little beyond even if we need to be.
I think all along our philosophy has been working very closely with the CDC, see what the CDC guidelines were, but going above and beyond what the CDC recommend has been our philosophy without going completely overboard. So if you want, since very early in October, when we knew that there's going to be screening at O'Hare, we started developing our protocols in conjunction with the CDC. And our philosophy has been go above and beyond what the CDC recommends, but don't go overboard. So it's basically creating that right balance. And as we worked very closely with the state, the final guidelines that came for the state of Illinois, I would say, and I'll defer to Dr. Hasbrook, has been going above and beyond, really without going overboard. That's the type of philosophy, just strike the right balance.
I would agree with that. And the other thing that I would want to point out, because sometimes this gets confused, there's a big difference between screening and diagnosis. This is a condition that can only be diagnosed with a lab confirmation. You got to take blood, take it to the lab, and confirm it. Screening just includes questions, a visual inspection, looking at that person, and asking about exposure. That's screening. So when we're talking about the endemic countries, the hot zone countries, they're asking the question, taking the temperature, visually inspecting them, and screening them, you know, and then they come over and they get the same thing. So they have not been diagnosed, they have not been tested, they've been screened, and that's a big difference.
I think an important thing to highlight, too, that was referenced with everyone up here is that the checks and balances that are kind of built into the system to try and mitigate the potential risks of any of the scenarios that have presented themselves. So the screening that happens outbound for the countries that are immediately affected, the screening that's happening here in the United States at those 5 points of entry is really that backstop, that double check to make sure that regardless of circumstances and screening that happened at the front end, that we will make sure that those folks are covered again. And really the best way when it comes to the guidance and things like that, both the consistency of the guidance that's being provided and the breadth of outreach is by far the most effective means of combating a lot of these issues that are out there. And I think that's what you've seen coordinated between local and state.
What I have, what I've taken from this is there's sort of these layers too, and that's assurance that there is those layers, because you will have individuals who will, you know, the doctor who may have been feeling, but you know, once you're screening, asking the questions, will slip through. So I mean, the fact that there is these sort of layers then is important to, I would say, to the public to be assured that we're, you know, if we missed it here, we'll pick, you know, we'll catch it over here.
I think that's a great point. I think the situation in New York City was actually a success because that person was being monitored and he knew where to call and who to call right away. So as soon as he developed those low-grade fever, he was able to notify appropriate people, get taken appropriately to the right healthcare facility where he could be handled, and those that cared for him were put at very little risk because they were all prepared enough to put on the appropriate PPE. So I feel like the systems that they used in New York are very much the systems that we have in place here to identify someone early and get them to the appropriate place as quickly as possible.
So, directors and doctor, you know, on behalf of all of us in General Assembly, just want to thank you very much for taking such a proactive view on this and working with us on a regular basis, and also working with our local first responders, our local health providers, our hospitals, to be sure that here in the state of Illinois we're as ready as we can be, to be sure that should a case present itself, we don't have any problems. So if you could, as you were talking about the 1,400 readiness responses, Dr. Hasbrook, that you've gotten, and that as you go down the chain, closer to the community level, there's still work to be done on training. I think all of us would appreciate, regular updates as those trainings are carried out and the status, so that we know that, not only are the resource network hospitals and the first responders fully prepared and trained, that we are completing this, because this will only serve us well, not only for a disease outbreak like this, but any serious epidemic disease that might come forward in the state of Illinois. So, ladies and gentlemen, thank you. And with that, we'll now hear from the Illinois Hospital Association on the state of readiness for our hospitals, with Dr. Derek Robinson and A.J. Wilhelmi.
Good morning, Mr. Chairman, Leader Belloc, Representatives Lilly and Hernandez. Good morning. My name is A.J. Wilhelmi. I'm the Chief Government Relations Officer for the Illinois Hospital Association, and joined today by my colleague, Dr. Derek Robinson, who is our IHA Executive Director of the Institute for Innovations in Care and Quality. And we're here on behalf of our over 200 hospital and nearly 50 health system members across the state of Illinois. And in particular, here on behalf of the 4 hospitals that were identified earlier in earlier testimony that have formed the Chicago Ebola Resource Network. And those 4 hospitals are Northwestern Memorial Hospital, Rush University Medical Center, University of Chicago Medical Center, and Lurie Children's Hospital, all in Chicago. And as you heard from both state and City of Chicago officials earlier today, the network has been activated and is ready to care for Ebola patients. And the reason for that is, and the reason they were identified, is because of their extraordinary capabilities and expertise at treating critically ill patients and patients with complex medical needs, and also because of their level of preparedness to date, including the effective training of healthcare workers. And so I want to just thank you, Mr. Chairman, for your comments at the outset about the hospitals in Illinois, especially the 4 resource hospitals, network hospitals that are really doing, I think you said, drilling and preparing. There's no question we're engaged in that activity. Also want to thank you, Leader Belloc, for your comments, and yours very recently, Mr. Chairman, about being proactive in this activity and in this discussion. And so that's why we're very happy to be here today to join in this important discussion. And at this time, I'd like to turn it over to my colleague, Dr. Robinson.
Thank you, A.J. Chairman Harris, Leader Belloc, and members of the committee, good morning. As we discuss our preparedness at the local and state level today, which has been prompted by the unprecedented Ebola health crisis in West Africa that has a global reach, it's important to note that Illinois joins an ongoing national conversation that hasn't ceased since the index patient, Mr. Duncan, was diagnosed on September 28th. Every day since then, like today, numerous federal, state, local agencies and industry experts have been collaborating to integrate the lessons that have been learned into our response readiness. First, I want to commend Dr. Hasbrook and Dr. Shakir, members of their team, in their leadership at the Illinois and Chicago Departments of Public Health, as they continue to provide critical guidance and direction to healthcare stakeholders and providers, including hospitals and health systems, on this important issue. As has been noted, I think it's important to mention that Illinois is a pioneer in emergency preparedness and response and has a well-established and long-standing infrastructure. The target focus on Ebola builds on our Illinois all-hazard response system, which was developed over several decades, where hospitals and local health departments serve as major anchors in the state's 11 regional health networks under IDPH and the Illinois Emergency Management Agency. Every day, Illinois hospitals and health systems prepare for all types of emergencies, from the seasonal flu to the H1N1 epidemic that we faced in 2009. And given the unique and evolving efforts of Ebola, hospitals and health systems are working every day more closely with our government partners and key stakeholders and other healthcare professional organizations, both formally and informally. For example, our president and CEO, Ms. Mary Jane Worth, sits on the governor's Ebola Viral Disease Task Force, which is led by Dr. Hasbrook. The October events that occurred with our country's first diagnosed Ebola patient in Dallas demonstrated the everyday reality that when people, no matter where they are, need health, especially in a crisis, they turn to hospitals 24 hours a day, 7 days a week, 365 days a year. They may arrive by ambulance or they may arrive by car or walk into a hospital, as Mr. Duncan did. And this reality certainly demands that we have a wide range of services and resources to meet the care needs, the ability to mobilize and coordinate care to a high level of service quickly. In particular, we're now becoming increasingly aware of how resource-intensive care for Ebola patients is, as estimates are surfacing that 25 to 40 healthcare professionals could be necessary to provide adequate care to an Ebola viral disease patient in a 24-hour period for just one patient. Healthcare worker safety has always been a top priority for hospitals and health systems, from protocols that are in place to protect from needle sticks, lifting injuries, other hazards, splashes. This is a 24/7 priority for our hospitals and health systems. And certainly because of the Dallas events, we're reminded of the need for adequate access to PPE or personal protective equipment for healthcare professionals. Now, when Ebola a viral disease patient is treated at a hospital, it's not a single department issue. It's an organization-wide response that's necessary. It involves our pre-hospital EMS personnel, the emergency department, transportation, housekeeping, radiology. It's an organization-wide effort involving nurses, physicians, and a number of professionals to help ensure that the needs of the patient are met. As you know, Illinois hospitals and health systems and their dedicated professionals provide vital quality, high-quality health care to Illinoisans 24 hours a day, 7 days a week, 365 days a year. And given the emergence of Ebola in the United States, our hospitals and health systems have been vigilantly preparing, reviewing appropriate protocols, and focusing on adherence to infection control procedures. In particular, the Chicago Ebola Resource Network, which is made up of the 4 hospitals that AJ mentioned earlier, have taken a leadership role in working together in collaboration with public health and emergency management officials. Fortunately, Illinois has not seen any confirmed cases of Ebola viral disease to date, and this has afforded us an opportunity to learn from the lessons of hospitals and public health systems in Atlanta, New York, Dallas, Nebraska, at the NIH, and allowed us to really work more closely with CDC and our state partners to accelerate our preparations. So I want to thank you for the opportunity to discuss this particular matter of importance before the committee, and be happy to entertain any questions that you might have.
Thank you, gentlemen. And before we go to questions, I just want to thank you guys and also the hospital partners that you represent. And I don't know if members of the committee have had opportunities, as I have, to talk to the leadership of the various resource network hospitals, but the amount of work and investment and preparation that have been done in a short span of time is, really, fairly astounding when you look at our hospitals in this state. So we're not only talking about being sure that doctors and nurses are prepared, but as Dr. Robinson mentioned, housekeeping staffs, nutrition staffs, laboratories, that there's physical plant changes being made in a number of hospitals to be sure that if a person does present that needs to be isolated, that their entire visit to a large, complex, complicated big city hospital, that patient is able to be isolated, so there's no threat of any kind of cross-contamination or exposure of people who are working in other capacities, or other patients, or members of the public who also may be coming in or out for different things. So, I mean, it's a huge investment that people have been making, and I think we need to acknowledge the fact that you guys have really stepped up and done this, because we are in a very complex environment, and people still need the comfort and the knowledge that should a case even present itself in the city, even though it may be in the same complex, that a patient being cared for in one area is totally isolated, and there would be no risk of exposure to anyone who is visiting or another patient in the area. So thank you very much for that. Do other folks have questions for Representative Belloc?
Again, I just want to ask the question as far as the hospitals go. So, as I asked Dr. Hasbrook, so are you having a conversation? I know my local hospital, because I was there for a legislative meeting, they're calling in every morning at 7:30 in the morning to somebody. I'm not sure if it's, that's why I asked Dr. Hasbrook who was really in charge. I don't know if they were calling into the CDC or to the Department of Public Health, but so you're going by the CDC guidelines for all of our hospitals, is that correct?
Our hospitals are following the guidelines that have been promulgated by CDC. They're working in conjunction with the Illinois Department of Public Health and our local health departments. Again, I think that all of our hospitals are maintaining a high index of suspicion and ensuring that there's appropriate screening in place. And so I think we've seen a number of efforts taking place both on the local level, the state level, and the national level across a number of organizations. So whether it's the American Hospital Association or various physician organizations, American College of Emergency Physicians, or the infectious disease specialists, the AMA, IDPH, CDPH, just layers and layers of readiness activity and information that's being promulgated throughout the healthcare system. So again, when we talk about Ebola viral disease, this is a new disease for the for the U.S. health system. So certainly it's something that I think folks are much more aware of and prepared for now than we were 6 weeks ago. And I think that level of preparedness will continue to improve and continue to accelerate because we do have a living and learning healthcare system.
Well, and I, as Chairman Harris just said too, I want to thank all of you from the Hospital Association. We've had a lot of bad times in the state with fiscal woes and everything, and whenever I give a talk and we're talking about things having a hard time, I always try to say how many good things we have in Illinois and the museums and the educational facilities, and I always bring up the healthcare facilities because I think we have some of the finest hospitals in the United States, and it's so reassuring to see that some of our very, very top hospitals have joined in Northwestern, Raj University of Chicago, and Lurie's in forming this coalition, because I think it means that they have taken that on as a responsibility because they are so excellent in what they do, but I think it also makes the rest of the people not only in our community in Northern Illinois, but the rest of the state to feel comfortable that our outstanding hospitals are part of this. So thank you very much. I appreciate it.
Thank you very much.
Gentlemen, thank you. I'm sorry, Representative Lilly had a question.
Yes. Thank you. I too want to thank you and commend you for being a part of a network that's calming our communities. I have one question, or two questions. You mentioned, I thought I heard you, I may have heard you wrong, it takes about 25 patients or healthcare workers to man or assist an Ebola patient. Did I hear you correctly?
Yes, ma'am.
With that fact, you indicated also that there may need more equipment to address those kinds of needs. What are some of your activities or issues to address those needs?
Sure. So there's been some discussion during today's testimony regarding the available PPE equipment here at the state level, and certainly you could imagine that on a national level, with the Ebola viral disease instances that have occurred in the United States, as well as several healthcare workers becoming infected, that all hospitals are really working diligently to get their hands on an adequate amount of personal protective equipment to ensure the protection of their workforce. And as was noted, there is a finite supply of that manufacturers are working to ramp up and get in coordination with CDC to the appropriate hospitals in some prioritized fashion. When you look at how long a patient, a healthcare worker can maintain the appropriate level of PPE on and provide adequate care to a patient, there is a finite time there. And so you have shifts of healthcare providers that will provide that intense level of care for a patient on those shifts kind of around the clock. And so when we look at the experiences of staff in Atlanta and in Nebraska and at NIH, those are the kind of estimated numbers that I think our hospitals are looking at for what it would take to care for one patient in the most severest state of Ebola viral disease during a 24-hour period. And so that gives you some sense of the volume of personal protective equipment that would be necessary during active treatment for one patient. And then on the back end, I think we're obviously working on some of the waste disposal requirements as well. So this has been a huge undertaking, and I appreciate the leadership that both our departments of public health as well as the hospitals and health systems have taken to ensure the appropriate level of readiness to provide protection for both the community that we serve as well as for healthcare workers that bravely take care of patients on a daily basis.
The number one question, and I work in a healthcare hospital, and number one question that the patients or visitors come in, they ask the question, do you have any Ebola cases? And of course I say no. However, what type of messaging are you providing to your local hospital to make sure that that message is really clear and crisp?
I think that our local hospitals, again, have a high level of readiness and preparedness to deal with this public health concern. I think this time of the year, one of the more important messages is that folks need to get their influenza vaccinations. We routinely encourage our healthcare workforce to get vaccinated for influenza as well. Much easier to transmit. Our chairman started off the committee hearing talking about that. A number of other illnesses like chickenpox, things that can be spread from person to person a lot more easily than Ebola viral disease. And so when I think of things that folks should be concerned about and what we can do to protect our community and to protect our workforce, there's some low-hanging fruit that the chairman has noted already.
Thank you.
You're welcome.
Thank you, Mr. Chairman.
And just to, reaffirm to you guys what, certainly we've talked about, outside of this hearing that, I stressed, to the departments of health, and the same message will go to the local health departments and clinics who are hearing next. We understand that, should Illinois ever have to respond to this, should this ever come here, this will be a massive undertaking, and it will be a costly undertaking, and that I think we as a state, will stand ready to, back up the different local groups, the providers, the emergency responders, local health departments, the clinics, because it may be more than a smaller organization can handle, and that's really what we're here for as a state and as a government, to be sure that in a crisis particularly, or an emergency, we're here, just as we are with floods, as we were last season with the tornadoes, when the time comes, that's what we're here for, is to, help back up our local folks. So thank you very much.
Thank you all very much. Thank you, Mr. Chairman.
Thank you.
So, with the other thing we know is that, there are other, ports of entry beyond hospitals where, people might, walk in and present with a case, or where people might come in and say, well, goodness, we have some of the symptoms, or we think we may have been exposed. And a lot of those facilities would be local doctors' offices, FQHCs, health clinics, especially that serve large populations, in dense urban areas. So I know that there's been a lot of diligent preparation being made by our local health offices also. So at this point, we're going to invite the Illinois Primary Healthcare Association up, and speaking on behalf of them will be Jordan Powell and Luis Jimenez from the Erie Family Health Center, who is, a perfect example of a very large, FQHC local health clinic that has been preparing and training its staff for the eventuality that somebody might come in with a concern. So if you could introduce yourselves and proceed.
Thank you, Mr. Chairman, Leader Belloc, and members of the committee. My name is Jordan Powell. I'm the Vice President of Governmental Affairs for the Illinois Primary Healthcare Association. We represent approximately 50 federally qualified health centers, or FQHCs, or community health centers as they're known, operating over 450 sites throughout the state of Illinois. And since the outbreak of Ebola, we have had an emergency preparedness coordinator that's been offering technical assistance to our health centers, as well as distributing up-to-date and official CDC, CDPH, and IDPH clinical advisories. Our coordinator has also been reaching out and gathering information from our member health centers on their training and educational efforts, as well as helping them with the acquisition of the proper personal protection equipment to really ensure that all FQHCs are adequately prepared. Now, due to the nature of Ebola having the symptoms of many other common illnesses, it is quite possible that cases will first seek out a health center primary care provider because of the trusted rapport that health centers have within their respective communities. With that said, I have with me today Luz Jimenez. She is the Senior Vice President of Clinical Operations for Erie Family Health Center right here in Chicago. And Erie is one of the largest health centers in Illinois and really offers a great representation of what all the health centers across the state are doing in response to Ebola. So now I'd like to turn it over to Luz Jimenez.
Thank you, Jordan. Thank you, Jordan. First, I'd like to thank the members of the committee for this opportunity to represent not just Erie Family Health Center, but other community health centers as we provide an overview of the activities that we've undertaken to educate and prepare our staff in the event that we are presented with a patient that meets the criteria for possible Ebola illness. As Jordan stated, my name is Luz Jimenez, and I am a registered nurse, first and foremost, and currently serve as Erie's Senior Vice President of Clinical Operations. I've worked at Erie for 13 years, and in my role, I am responsible for directly and indirectly overseeing the clinical support staff and the services that we provide to our patients. Just a little bit about Erie. We serve approximately 59,000 patients across 13 facilities. 11 of those facilities are in Chicago. One is in Evanston and one is in Waukegan. We have a little over 500 employees and volunteers. Erie started to ramp up its preparation activities around Ebola around mid-October after we received a call from one of our patients who was pregnant and was reporting some symptoms of vomiting and fever. It happened that this patient's mother had recently traveled from Nigeria, which was at that point still an area of concern, and her husband was also sick with similar symptoms. The nursing staff who first received the call from the family were wise enough to call our infection control nurse. Her name is Rachel Wallace, who just happened to be in my office at the time. And so we immediately were able to call the Chicago Department of Public Health and reached out to our hospital partner, Northwestern, and received immediate guidance on what to do. Happily, that, of course, turned out to be a false alarm, and that family was released later that day. But that call really helped us to see that we needed to significantly speed up our efforts, our training and education at Erie. And so initially, I partnered with our Chief Medical Officer, Dr. David Buchanan, and our infection control nurse, who I've already mentioned, Rachel, to develop a plan of action. Our plan initially began with primarily informing ourselves as much as we could about Ebola and the potential risk that we might face at the health center level. We attended every possible webinar between the three of us that were being presented by the Department of Health, including attending the Chicago Health Coalition meeting in October. Rachel and I also happen to be members of the Emergency Preparedness Advisory Work Group of the Illinois Primary Healthcare Association. We are members of Health Alert Network, and so we had no shortage of good information, particularly from the Chicago Department of Public Health. So what we did is we developed trainings. We knew we needed to develop materials that we could hand out to our staff. As soon as we were able, we put together a presentation that was sent to our staff with active links to the latest information on the CDC website. And we developed algorithms for managing a patient who would potentially present to one of our facilities or even call us by phone. We were eagerly anticipating information from the health department on outpatient management of patients who met the criteria for possible Ebola, and as soon as those guidelines were released, we updated our own internal materials and sent the guidelines to our staff. We placed signage at all of our points of entry to our waiting rooms, asking patients to let us know if they had traveled to West Africa in the past 21 days, and also to let us know if they were sick. We met with our hospital partners to ensure that we were on the same page about how we would respond to any suspected cases. And of course, we ordered additional personal protective equipment, and to the best of our ability, we put together kits that we felt closely adhered to the recommended guidelines. Some challenges, as you've heard with the personal protective equipment, is that there is a back order. Initially, our kits contained impermeable gowns that actually needed to be doubled because they didn't go completely around the individual. They included foot coverings that did not rise to the level of the knee. And so we have since ordered additional equipment that we think will provide more coverage, but again, we're told that these supplies are on back order. Most recently, we provided in-person training on donning and doffing personal protective equipment for our providers, our nurses, our dental assistants, lab assistants, and medical assistants. And we have provided those instructions in writing and recorded these training sessions for review at a later time by any staff who wish to do so. Additionally, we created scripts for our front desk staff and our call center staff to follow for screening our patients. We are adding messaging to our on-hold message of our phone tree so that patients will know and expect that we will be screening them as they arrive for their appointments or even over the phone. We've purchased additional hand sanitizer and mask stations. This sounds like a small thing, but understanding that we have patients coming into our health centers, potentially sitting down, waiting in a room with other patients, what we've done is provided signage and asked them to help themselves to these materials. In the event that they don't, our front desk staff also has these supplies available. And then we asked our clinic directors to complete documents detailing the logistics of isolating a patient if necessary. We asked them to identify isolation rooms in their clinic. We asked them to identify where they will store personal protective equipment, and then to think through and document the steps that they will follow in moving a patient from the waiting area into the identified isolation room. Lastly, we're in the process of planning drills so that staff is clear on how to respond in the clinic to a patient who answers positively to our screening questions. I would say that generally summarizes the steps that we've taken to prepare. Certainly looking to the Chicago Department of Public Health for guidance, which we have received consistently, and to the Illinois Primary Health Care Association, who has also consistently kept us up to date. I would say that our current challenges are likely similar to other community health centers, and that they include making sure our staff not only receive, but read all updated information in a timely way, that we provide time for clinical staff to practice donning and doffing personal protective equipment, as that does take some time, and it is generally challenging to do as you're trying to carry out your normal activities in caring for patients. Receiving and distributing the appropriate personal protective equipment, I think, is still a concern. And then last but not least, allaying the fears of staff so that they consistently screen patients and then respond appropriately in the event that we should have a patient that meets the criteria. Something that we have done is we have, in terms of trying to allay fear, we want everyone to take this very seriously. We want everyone to be prepared. But as you have said, Mr. Chairman, we have a much greater risk of being exposed to the flu every day in our health centers, or to TB and other potentially contagious illnesses. And so our hope is that we would train our staff to be prepared in every way. And we want to make sure that we have the supplies that are necessary to do that. Thank you.
So thank you. And when I visited Erie and the other FQHCs in my area, the other thing you guys bring, besides being very close to the community at the local level, is such a multicultural approach. And in a very diverse area such as that I represent, where there are 63 different cultures and languages regularly spoken, you have folks who can communicate in all those languages and get the message out, to a lot of different people in a way that they'll be ready to take on. And I think that's incredibly important, that we're being sure that all the different health concerns are being met, as well as Ebola. So I think Representative Fernandez had a question.
Just a quick question. And I just want to commend you because at a, FQHC, that level, I mean, you're setting sort of the example for that community level. So your quick response and preparing yourself, I mean, maybe it's a blessing in disguise that these individuals who were diagnosed, that they were free of possibility of Ebola. And so this was a good way then just to start preparing. Just a quick question regarding your screening. So when individuals are calling, is this kind of a set guideline that you've placed that those who are making appointments, you screen them immediately of what the symptoms are, so from the very get-go, or is this dependent upon what they're calling for, to make an appointment?
Well, we have various ways that patients will reach out to us, and one is through our centralized call center where we have telephone triage nurses. And so often a patient has the ability to call us and select the option to speak to a nurse directly if they are ill. And so these nurses have been trained to ask the questions, to ask the patient to inform them if they've traveled to these 3 endemic areas. It's obviously not something that we would do in other circumstances, but we are trying to follow as much as possible the guidelines that have been put out. And so both our front desk staff and our call center staff should be asking these screening questions.
Okay, so so this is an added guideline to.
Yes.
Okay, thank you.
Yes.
And just one other question occurs to me. Our FQHCs, there is a network, emergency distribution network called Siren, which is part of the state of Illinois, which immediately flashes out updates on any number of emergency topics. Are FQHCs members of that network? Do you know, or this might be a question for Dr. Hasbrook or Director Monka? He's shaking his head. I get the thumbs up.
Yes, I can say that certainly Erie Family Health Center is.
Good. So if there are emergency guidances, then you would get the most up-to-date information or advice. Great. Thank you. Other questions? Thank you very much.
Thank you.
So the last group that we will have are, and I think we'll take them as a whole, are our local health departments and Public Health Association. So a lot of questions came up in some of the earlier discussions about, what are the different responsibilities of the state of Illinois, city of Chicago, and local health departments around the state. So we have, 4 folks here who are, eminently able to testify about that. So let's start at my left and house right, if I remember my stage directions. So if you could introduce yourself and just come down the panel.
George Z. Teller from the DuPage County Health Department.
Tony Beltran from the Lake County Health Department.
Dr. Catherine Kennard, Director of the Village of Skokie Health Department.
And I'm Tom Hughes. I'm Executive Director of the Illinois Public Health Association.
So Dr. Teller, you want to start? Or, okay.
Good morning. Thank you, Chairman Harris, Leader Belloc, and Representative Lilly and Hernandez. So we would like to give you some perspective from the local health department and also represent the Northern Illinois Public Health Consortium, which is a membership of multiple local health departments, including the City of Chicago, the Village of Skokie, as well as the counties of Cook, DuPage, Grundy, Kane, Kendall, Lake, McHenry, Will, and Winnebago. Together, we represent about 8.5 million Illinois residents, so about 2/3 of the population in Illinois. I won't go into details in terms of some of the requirements that may come related to the airport screenings. Some of those individuals that come through may actually reside in one of our counties, and so we wanted to give you a little bit of information about how that would actually work. And we really have 3 main messages First, state and federal funding is needed for these isolation and quarantine activities. We want to make sure, second, that we have an appropriate and consistent approach to dealing with individuals that have been exposed to the Ebola virus. And third, making sure that we have state lab capacity for this work. So I'm going to touch on the first item, the additional funding that's needed at the local level. So you heard a lot of the activities earlier in terms of what would happen with isolation and quarantine procedures, and many of those activities will actually happen at the local level in conjunction with the Illinois Department of Public Health. What it does mean, though, is many of those activities land on the doorsteps of our local health departments. So some of those activities we would be the groups that would do the social distancing activities. So we would make sure that individuals that were in isolation and quarantine actually follow those. We would issue the orders to restrict travel. These are some of the responsibilities that that have been delegated to us as local health departments that we do in conjunction with the Illinois Department of Public Health. We would monitor individuals with known exposures. So some of that information you heard earlier in terms of temperatures and things like that, that would be work that we would be doing at the local departments. We would ensure compliance with any court-mandated order for quarantine, and especially if someone is non-compliant. We would collaborate in terms of doing contact tracing for someone if they do become sick, to make sure that we would be able to see who else was exposed, potentially exposed. We do a lot of work with our local health systems to make sure that they're prepared and that the transport that may be needed for someone in terms of care for an Ebola patient is happening, as well as making sure that our hospitals are prepared, so we help coordinate some of that efforts as well. And then a lot of what we do is really distribute information that's evidence-based to our local partners, and in order to have the proper information. So we do receive preparedness funding, and many of that funding is already directed towards activities of planning and building capacity for things like mass vaccinations or antibiotics and things like that. An Ebola response will require different activities than we currently do, and would result in new costs to certified local health departments in the state of Illinois. There's an estimate that it could cost us for one person up to $1,000 in excess of that per day to care for things like housing, food, as well as other supportive services. And while we definitely take the public health orders very seriously, we also want to make sure that we're thinking about the individual liberties of those individuals. So, as was described earlier, not going above beyond what we need to do that becomes too restrictive for individuals. So we would collaborate, if we did have a case, we would collaborate with the Illinois Department of Public Health on that. So one of the things that other states have considered is a fund, so that if workers were, in the course of their work, were exposed to a patient with Ebola and needed quarantine, that they would actually have a fund to help cover some of that, so there would not be a loss of wages to those individuals, and the public health officials would be able to care for their families if they had that, in terms of having sick or vacation days, or even paid time off during that quarantine. So with that, I'm going to pass it over to Dr. Kennard, who's going to go into more of the details on the standards.
Good morning, Chairman Harris, Leader Belloc, and other representatives. I'm Dr. Catherine Kennard, a physician and director of the Village of Skokie Health Department. And I wanted to just say a word again emphasizing how we are collaborating across our large region through the Northern Illinois Public Health Consortium and with the Illinois Department of Public Health, as well as the City of Chicago, regarding quarantine and isolation. Because Ebola and other infectious diseases recognize no jurisdictional borders, NIFIC believes jurisdictions should adopt a standardized approach for monitoring persons with potential exposures to the Ebola virus that is consistent with the principles outlined in the latest CDC guidance to ensure individuals throughout the country and our region are treated fairly and predictably. Informed by the best available scientific evidence, NIFIC echoes others in the medical community, such as the American Medical Association, Infectious Disease Society of America, Pediatric Infectious Disease Society, and the Association for Professionals in Infection Control and Epidemiology, opposing quarantine policies that are not grounded in science. Our intent is to follow the most recent, appropriate, and consistent monitoring of movement guidance provided to local health departments by the CDC and the Illinois Department of Public Health. It's very important that we're all following the same consistent standards, and I wanted to assure you that we are. We recognize also, though, at the local level, the increased level of public concern regarding Ebola virus cases, even in situations where the risk is non-existent or very low. Accordingly, we are taking specific steps to rapidly address the activities of persons under monitoring and minimize the perception of risk by providing the appropriate messaging to the public. In short, public health officials at the state and local level are working together to determine the best course of action for their communities and regionally. We have worked closely with many community partners to review our procedures, and in the event that a person being monitored becomes ill, we will implement a call-ahead notification to emergency medical service transport to assure they are donning the appropriate personal protective equipment, and to the receiving hospital to assure appropriate isolation and testing are performed. Again, this is all happening through the local health department where this is occurring. We are implementing the requisite standards and protocols that strike the right balance and are responding in a manner that is grounded in science. Thank you for the opportunity to testify regarding this important public health issue. And Tom Hughes from the Illinois Public Health Association will discuss priority number 3, the need for improved state laboratory infrastructure and capacity.
Thank you, Dr. Kennard. Chairman Harris, Representative Belloc, Hernandez, and Camille Lilly, thank you so much for allowing me the opportunity to testify. A very famous Chicago politician once said, "Never let a good crisis go to waste." And so I'm going to follow in that vein when I discuss the state laboratories with you. My name is Tom Hughes. Again, I'm Executive Director of the Illinois Public Health Association, and I'm here on behalf of more than our 100 affiliate organizations and our nearly 8,000 members across Illinois. I'm also a former Deputy Director of the Illinois Department of Public Health, where I had general supervision over infectious diseases and the state laboratory. The Illinois Department of Public Health has 3 laboratories located in Springfield, Carbondale, and Chicago. The 3 laboratories provide surveillance testing for public health programs. The largest of the 3 labs is located here in Chicago and has almost 2/3 of the employees. The Chicago laboratory is a significant part of the laboratory system for the state because it is a site where all newborn screening and tuberculosis testing is performed. It houses laboratory services to support the public health programs of the city of Chicago. It is the bioterrorism reference laboratory for Chicago and the Collier counties. The Chicago laboratory houses the U.S. Department of Homeland Security BioWatch program, which monitors on a daily basis air samples for bioterrorism threats. The Chicago laboratory is also now will perform sensitive Ebola testing. Chicago is a major domestic and international transportation hub and entry into the U.S., and this lab and all the labs are frontline to public health readiness. Prior to my departure from the state in 2008, I asked for and received permission for the Association of Public Health Laboratories to send a team of public health laboratory directors in to evaluate the facility and perform an assessment of its current condition. The team spent several days inspecting the facility, interviewing the laboratory staff, and program staff that depend upon the laboratory's data. In 2013 and 14, the CDB also performed an evaluation of the physical condition of the Chicago laboratory and prepared statements of the necessary work. Those evaluation projects resulted in the following recommendations for the building, and in almost all cases reflect the original APHL report. The facility is housed in a building at the University of Chicago Medical District. The laboratory shares its space with the university and its students, which can at times make it difficult to secure all areas of the building. The laboratory occupies space on 5 floors, requiring shared elevators to move samples, infectious waste, staff, and members of the public. The CDB architects evaluated those elevators and determined that they should be replaced. The heating, ventilation, air conditioning ductwork in the ceiling areas have been compromised for as long as I can remember. Cracked seals, corroded ducts, poorly installed ventilation and exhaust registers, incomplete seals are present at the juncture with the walls and the ceilings. In addition, almost every testing area has at times experienced inadequate temperature control, which can affect sample testing. Modern laboratory instruments can produce significant heat and require a certain temperature range in which for their performance to be at optimal standards. Also, many tests must be conducted within a specific temperature range. The APHL report and the CDB architects indicated that the heating, ventilation, air conditioning systems required a total renovation. This included replacing heating boilers, air handling units, distribution pumps, cooling towers, and temperature control systems. The CDB also indicated that work would include repairing exit doors, adding a backup heat exchanger for domestic hot water, and upgrading the elevators and replacing all light fixtures. The project to renovate would also require funding for abatement of asbestos-containing materials. In the basement of the building, there are periodic problems with odors and occasional sewage backup. The building wastewater system is below the city's sewage system, requiring pumping of waste into the city system. When the pumps aren't working, which has happened, the building's wastewater has no outlet, and there are no means to keep the city waste and sewage out of the building. At one point during my tenure, I used $300,000 of the Office of Health Protection funds to shore up the electrical system and to help prevent power losses and to allow for the purchase of new equipment, which was deemed necessary by the passage of legislation for increased newborn screening. Ceiling tiles have water stains on them throughout the building, suggesting that the drain system is deteriorated and is leaking. In the last few years, numerous leaks have occurred within the building, which have postponed testing. I have myself seen garbage bags covering sensitive testing equipment. The plumbing system delivers poor water quality, insufficient hot water, inadequate water pressure. These factors affect safety features like eye wash stations and decontamination showers, as well as basic sanitation. The original report and my own tour with the APHL individuals, we saw inoperable eye wash stations and decontamination showers. The CDB architects indicated that all emergency showers and associated plumbing should be replaced, consistent with the APHL report. The building design does not lend itself to the needs of modern laboratory methods. Molecular testing, such as DNA analysis, requires separate, very clean areas for sample preparation and processing. These conditions are almost impossible to achieve in this facility. The BSL-3 laboratories are and frequently have experienced a loss of negative air pressure. These failures can provide unsafe working conditions for staff who are working with dangerous organisms. There have been repeated BSL-3 failures during my tenure and over the past few years. Chairman Harris, you and I are very aware of these conditions. I've expressed those to you in the past. I don't think that it is the fault of any staff or any administration or any director. I think it is a situation of competing budget interests over the years. And I have great confidence in this director and the laboratory directors to provide a safe working environment. But these conditions that I've outlined for you only make Dr. Hasbrook and the laboratory staff's work that much more difficult. I recommend that you make sure that the Springfield and Carbondale labs are able to support redundancy of operations, that you continue to work with Dr. Hasbrook to assess the needs of this laboratory. And frankly, given the condition of this state lab, I think you need to think long-term and look at either building a new facility within the medical district in cooperation with the University of Illinois School of Public Health, or at least with the State Police Forensic Lab that is in the same area. I don't want to sound alarmist, but I've been talking about these conditions since probably 2005, 2006, and I just think it's time that we take a long, hard look at where the future lies with this laboratory. Thank you.
Does that conclude everyone? Okay, so just two questions. First, for Mr. Hughes, I've toured that lab, and certainly, like so many other assets that the state has, it is in dire need of some investment. What are the current cost estimates to repair or replace that facility?
Mr. Chairman, I can only go back in 2007. It was deemed really not feasible to repair, and we looked at replacement. Back in that time period, it was $120 million to $160 million to replace. I'm not sure if they've done any. I know that there was some funds appropriated to CDB for looking at replacement, but I don't know if that was followed through on or if there have been architectural renderings.
Right. And then for Mr. Beltran, you mentioned other states have set up funds to, this is something, again, as we're thinking this through, that we may need to contemplate that, if we do get cases, then some people might, have to, lose wages, or we might have to supplement, housing or, other expenses. Have there been dollar figures attached to any of those other state funds? Like, what are the ranges we should be thinking about?
I apologize, and to clarify, it's Ohio and New York that are considering, so they're working on their legislation right now, and I don't have dollar figures for them.
Okay. If you can help, monitor that, and if you get copies of what those are, I think these are all worthy things that we need to look into, from a contingency perspective, and certainly, from looking at the capital needs of the Chicago lab, which I did tour, and I was very glad to wash my hands when I left.
I was there too.
Yeah, I got a lot of germs in there. Representative Belloc.
Thank you very much. So that lab that you were discussing, I think at one point you said University of Chicago, but is it University of Illinois? Or
I'm sorry, it's University of Illinois at Chicago, UIC School of Public Health.
Yeah, that's what I thought. Okay. But our Department of Public Health, the funding comes through state of Illinois in maintaining the lab. So if you were to build a new one, that would be state funding for the whole.
Well, I would recommend that because it is housed at UIC, and I've had discussions in the past with people at UIC about cooperating and collaborating on building a new department or new laboratory,
right?
Which, because it is a learning teaching facility, I think it would be a great asset for not only the state, the city, but for the school to look at a collaboration in that manner.
Okay, thank you.
Representatives Lilly or Hernandez, anything? Well, Doctor, gentlemen, thank you very much.
Thank you.
I did not have any other witness slips. Was there anyone else here who wished to offer testimony? That being the case, I just want to thank everyone. We may be back to discuss this further should the situation warrant, if things change dramatically in the state of Illinois. But thank you very much for the information, and we shall stand at recess to the call of the chair.